Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by independent educational grants from Ipsen and Myram Pharmaceuticals.
Hello, everyone, and welcome to today's webinar. I am Tatiana Kushner. I'm an associate professor of medicine in the Division of Gastroenterology and Hepatology at Weill Cornell Medicine, and also have a joint appointment in the Division of Obstetrics and Gynecology. And today we'll be discussing the topic of progressive familial intrahepatic cholestasis, or PFIC, and we'll really tailor the discussion around a case that we received from the community, which illustrates some of the key points when thinking about these complex conditions. What I hope to do today is to provide a little bit of an overview, but then use this case that was submitted to illustrate several key aspects, specifically the genetics of PFIC, how we can incorporate genetic testing in the assessment and treatment of PFIC, family counseling and team-based care approaches and management of these conditions. So when we think about PFIC, the first question is, what really are these conditions called PFIC? And really, this is a group of conditions that causes defects in bile absorption and flow and subsequent accumulation of bile acids, which in turn is associated with the symptoms of pruritus and cholestasis that are associated with these conditions. Notably, these conditions are quite rare, with an estimated prevalence of 1 to 2 per 100,000. And what's challenging is that the clinical course and prognosis vary by type, and there are multiple types. And there are also multiple genes that have been implicated in these set of conditions called PFIC. And so, where the gene defect occurs can, of course, influence the phenotype of the condition. It is important to recognize that homozygous presentation, where both alleles of this particular gene are affected, is not surprisingly associated with earlier onset of disease, classically in early pediatric age, and a more severe presentation. However, individuals can also have autosomal recessive conditions where there's a heterozygous mutation, so only one allele is affected. And in these cases, there may also be associated symptoms and conditions that we see in the context of a heterozygous mutation. And we'll talk about some of these, but some examples that are listed here, which include intrahepatic cholestasis of pregnancy, which is a condition that we see in pregnancy where cholestasis occurs, cholelithiasis or choledocholithiasis, predisposition to drug-induced liver injury. So someone with a heterozygous mutation can be predisposed to liver injury in the setting of certain drug exposures, and parental nutrition associated liver disease. And these are just some of the examples of conditions that can occur with a heterozygous mutation. So there are multiple disease subtypes, as I mentioned, and some are depicted here. So we have different types of PFIC. Here they're numbered from 1 to 6. And as you see, the different PFIC types are associated with mutations in different genes, which in turn are associated with altered activity of different proteins. And typically, they have certain presentations that are, for the most part, again, in homozygous mutations, quite severe and occurring early in childhood. Although I'll point your attention to PFIC3, which occurs in the setting of a mutation in the ABCB4 gene, which affects the MDR3 protein. And in this particular genetic mutation, particularly with heterozygous mutations, you can have presentation that occurs later in life, including in adolescence and early adulthood. And as someone who practices in the adult field, this is one that I would particularly perhaps be looking for in someone who presents with onset of disease later in life. So, there are distinct features in these different PFIC types, and they're listed here. Um, and the defining feature, they all have cholestasis as part of their uh, clinical presentation, but depending on which type, they may also have other uh, affected organ systems outside of the liver. So, for example, in PFIC1, can be associated with diarrhea, pancreatitis, hearing loss, and short stature. And then you can see descriptions of them throughout. One additional feature that is important to recognize is whether they have elevated GGT. So, when you suspect PFIC in a patient, it is important to include the GGT in your assessment when you check the liver enzymes, not just the alkaline phosphatase. And that's because that can help you narrow down which of the PFICs may be at play here. Because, in particular, the PFIC3 or ABCB4, which I already mentioned, which affects the MDR3 protein, its mechanism is such that it leads to the absence of biliary phospholipids that allows bile acids to directly injure the bile duct epithelium. And so, as a result, those patients will have elevated GGT due to damage to the actual bile duct. Whereas if you look at the other PFIC types, they would have low or normal GGT, classically speaking, because they don't have a direct injury on the bile duct, but they do have accumulation of bile acids and cholestasis. So GGT is an important consideration when you're ordering a workup in someone in whom you suspect PFIC. Additionally, when thinking about symptoms that are associated with the cholestasis, pruritus or itching is really the most common symptom that we think about with these conditions and a disabling symptom. And so, again, when we're thinking about patients where we may suspect this condition, individuals who have signs of cholestasis and the symptom of pruritus is someone who you may consider evaluation for PFIC. Now, delving in a little bit more into ABCB4, MDR3 deficiency, which I mentioned is one that we think about more commonly in adult presentation, perhaps. As I mentioned, with this condition, there's decreased phospholipids in the bile, which directly leads to damage to the biliary duct epithelium, which can then lead to elevated GGT. In addition, in this gene mutation, there's increased cholesterol saturation. So it's common to see gallstone formation or cholelithiasis in patients who have this condition. Notably, as we mentioned before, if they have a biallelic mutation, they're homozygous, then they have the full-blown syndrome of PFIC3, which leads to rapidly progressive liver disease and cirrhosis. However, if they only have monoallelic mutation, they're heterozygous carriers, then they can present with other types of symptoms and syndromes, which are listed here. So, they can present with intrahepatic cholestasis of pregnancy, which again is the symptoms of cholestasis, particularly during pregnancy. Other syndromes that patients with ABCD4 heterozygous mutations can have include LPAC, which is low phospholipid associated cholelithiasis. So, in these patients, you would want to get some imaging to look for signs of gallstones because of the cholelithiasis as part of this feature. A classic symptom with this would be that they would have had a cholecystectomy early in life due to cholelithiasis. Drug-induced cholestasis is another one, and some potentially can develop later onset cirrhosis, so more indolent progression of disease that lead to later onset of advanced liver disease. And then also, in the literature and some of the registry population-based studies, there has been association seen with cancers, including cholangiocarcinoma and hepatocellular carcinoma. So, how do we incorporate genetic testing when we think about the assessment and treatment of these conditions of PFIC? I would start by saying that the guidelines are not entirely clearly defined, particularly in the adult population. I would also point you to the European Association for the Study of Liver guideline document on cholestatic liver diseases, which we include as citations in the slide set, which really provides a nice discussion of where you would consider genetic testing, particularly in the adult setting. But broadly speaking, when would you consider genetic testing? Well, we, over time, have increased our knowledge of the genetics that are associated with these conditions. So we can offer genetic testing to more people, but we should be aware that there are a number of variants of uncertain significance that we may find. And so when offering genetic testing, it's important to counsel patients ahead of time that this may be a result and that it may be difficult to interpret and may complicate patient counseling and management as opposed to simplified patient counseling and management. Nonetheless, there are certain indications, particularly in the adult population for ABCB4 genetic testing. That includes severe intrahepatic cholestasis of pregnancy, the presenting symptoms of LPAC, unexplained atypical or treatment refractory cholestasis. So, if you're following patients who you've ruled out all the other chronic liver diseases and they have persistent symptoms and cholestasis and perhaps pruritus, those are individuals that you can consider genetic testing in. Additionally, cryptogenic cirrhosis, so individuals with advanced liver disease without a clear etiology. And then family history also can provide some justification looking for genetics as an etiology of a chronic liver disease. And most typically, genetic testing is offered after a comprehensive evaluation is performed to evaluate the condition with labs, imaging such as MRCP, and perhaps liver biopsy. And if, despite this workup, there's no clear etiology, then genetic testing can be considered. Now, in terms of genetic counseling based on the EASL guidance that document that I mentioned uh, should be offered to patients and at-risk family members, ideally prior to genetic testing. And this early counseling can help with interpretation of the subsequent results, diagnosis, prognosis, management, and even family planning. Notably, as we mentioned, PFIC is autosomal recessive, so siblings may have a 25% risk of carrying that genetic mutation as well. And you can offer counseling and cascade testing to asymptomatic siblings, depending on the situation. Genetic testing, to be more specific, should be offered to first degree relatives of patients with confirmed MDR3 deficiency. And some carriers have higher risk of developing fibrosis and cirrhosis or liver cancer. So you may consider offering genetic testing to them as well. And then you should prioritize testing and counseling for women of childbearing age because if they have these mutations, there may be at increased risk for cholestasis of pregnancy. Now, how does genotype affect management? Well, We know that if there's biallelic ABCB4 variants, genetics can be used to predict not just the phenotype, but also response to ursodiol therapy. And so, if individuals have the biallelic variants, they will be more likely to respond to ursodiol and for sure should be treated with ursodiol. However, in those that are carriers or heterozygous ABCB4 variants, the situation is not entirely clear. And I think we're still learning more about what is the true clinical course of individuals who are heterozygous for ABCB4. On the right here, you see a study described where this is a retrospective cohort study of adult carriers of heterozygous ABCB4 variants. And they had 67 participants who they evaluated for quality of life measures, pruritus, as well as long term clinical outcomes, and compared their course to patients with primary biliary cholangitis and primary sclerosing cholangitis. And what they found is that overall, their transplant-free survival was excellent. That many of them had received ursodiol at some point. Interestingly, although when compared to PBC and PSC patients, there was not significantly more pruritus in this patient population, they did actually have a significantly lower reported quality of life. And so, one question is what is driving this lower quality of life among these patients with these genetic variants? And again, I think there's still more to learn about that. But also importantly, they did have a few patients in that study who developed cholangiocarcinoma who were ABCB4 heterozygous. And again, that points to the question and the potential importance of follow up for these patients who may be at increased risk of developing these malignancies. So, how do we treat PFIC or ABCB4 associated disease? Well, again, ursodiol is really the first line treatment that we have available. The goal would be to improve pruritus, improve nutritional status, and treat complications related to advanced liver disease. And although it is the first line, it's really off label. But a number of patients do respond to treatment. And there is some thought that actually treating with ursodiol can induce the expression of these genetic variants, such as ABCB11 and ABCB4, and therefore increase the secretion of bile acids and phospholipids into the bile, thereby decreasing that damage that we're seeing to the biliary duct epithelial. So, ursodiol may have multiple mechanisms of action that can be potentially beneficial. Now, ursodiol does not work in 30% or more of patients. So, second line agents have also been investigated in treatment of PFIC. And the second line agents that are have been investigated are called IBAT inhibitors or ileal bile acid transporter inhibitors, which function by causing excretion of the excess bile acids into the intestinal tract. Um, and therefore interrupting the enterohepatic circulation. And there have been two IVAT inhibitors, odevixibat and maralixibat, that have been evaluated for the treatment of patients with PFIC. And I'll just show you very briefly the trials that have investigated these drugs. Both of the trials for both of these agents were conducted in a pediatric patient population for patients with PFIC. And overall, this is results from the PFIC 1 and 2 um, study. This is the interim result, and it showed that in those individuals treated with odevixibat, they had reductions in serum bile acids and improvements in itching. And importantly, in the pediatric population, mean improvements in growth, which is quite important. And overall, it was generally well tolerated. There was also the study March, which evaluated maralixibat. This also was conducted in a pediatric population, and the goal of the study was to evaluate impact on pruritus, bile acids or cholestasis, as well as growth scores, and also was found to be beneficial. And when you compare both, the study designs were somewhat different, but overall, they were both effective in improving pruritus and cholestasis. And the treatment associated adverse events were not severe, but the one to note about these agents is that the most common side effect typically is diarrhea due to the mechanism of action of these agents. So as a result of these studies, now we have availability of these agents for treatment of PFIC, available both in the US and Europe. The only real difference is the age cutoff at which you can start using these agents, but they're approved for PFIC in treatment of cholestatic pruritus. So for people who have PFIC and who have itching. So now let's get to our case. So this is a case that was a 33-year-old woman, and she presented at 21 weeks gestation with complaints of elevated liver tests. Now, in her first pregnancy, she did have a diagnosed ICP, and now she presents during pregnancy with elevated liver tests. And notably, in her history, she had a history of a cholecystectomy. So she had a gallbladder resection early in life. She was from Ecuador and denied alcohol use. And family history, there was no history of known liver disease in her case. And so blood work was obtained throughout her pregnancy. And what you see here is that her liver enzymes were elevated, including the AST, ALT, and alkaline phosphatase. Notably, GGT was not obtained. And as I mentioned, it would have been important to see the GGT to perhaps, if you're thinking about PFIC, to begin to narrow down your considerations. Notably, at 26 weeks, her bile acids were checked, and they were actually normal at that time. She denied any symptoms and denied any abdominal pain. So, what would be the first step in the diagnostic workups? So, the first step is to do evaluation to rule out or evaluate for chronic liver diseases. Ultrasound is important as well, particularly if you're thinking about gallstones, although she did have a cholecystectomy in the past. So, her evaluation is shown here. She underwent workup for chronic liver disease, and everything was largely negative. Um, she was immune to hepatitis A, but otherwise all workup was negative. And her ultrasound was only significant for a surgically absent gallbladder, but the liver looked completely normal. Notably, she did have a FibroScan or transient elastography test, which suggested that maybe there was some fatty liver, but otherwise it was normal liver stiffness, so no evidence of fibrosis, and at least per FibroScan evaluation. So the case continued, and at 35 weeks gestation, later on in pregnancy, she did actually continue to have elevated liver tests, but now developed elevated bile acids. So her bile acids were over 10, which is consistent with a diagnosis of cholestasis of pregnancy. And at that point, ursodiol was initiated for treatment of cholestasis of pregnancy. And she was induced for delivery at 37 weeks gestation. So she was seen for postpartum follow up after pregnancy delivery, where presumably everything should resolve if this is intrahepatic cholestasis of pregnancy. However, her liver tests were found to still be elevated at 8 weeks postpartum with an alkaline phosphatase of 256, and her bile acids were 13, so still mildly elevated. So, what would be your next step now? Would you A, assess for pruritus and start ursodiol, B, assess for pruritus and perform additional lab work, or C, assess for pruritus and perform another liver biopsy? All right, so it's not 100% clear cut. This is the type of case where I would involve the opinions of my colleagues to see, well, should we do another biopsy? What may be going on? But for starters, yes, additional blood work and assessment of pruritus. So you begin to think, could this be PFIC? There was persistent elevation of liver tests postpartum, so there was a question of whether this could be something outside of just intrahepatic cholestasis of pregnancy. So, what other test would you order next? Would you order an MRI, a genetic panel, a liver biopsy, or no other test, but wait and see her at 6 months postpartum to see if liver tests are still elevated at that point? So I agree with the genetic panel. I think MRCP also would be reasonable in this context if she has not had one to look for any biliary etiologies as well. So she underwent genetic testing, and her genetic test revealed an ABCB4 mutation. This is a printout of the genetic testing results that were submitted. She was a heterozygous carrier for this ABCB4 mutation. In summary, then, given that her liver tests continued to be elevated outside of the pregnancy setting, she had um, ICP, and now she has this ABCB4 mutation. This case was consistent with ABCB4 associated disease. And she's a heterozygous carrier for ABCB4 mutation. So now that we have these genetic test results, would you be satisfied with PFIC as the explanation of elevated liver tests? And what would you recommend regarding long-term follow-up? Yeah, so again, she has heterozygous ABCB4 disease. It was manifesting as intrahepatic cholestasis of pregnancy, history of cholecystectomy with prior gallstones, and also possible LPAC, given that, again, she had cholecystectomy early in life. So, based on EASL guidance, what is the recommended follow-up screening for patients with ICP? Do you recommend continued follow-up every 6 months, yearly for those with abnormal liver function tests after pregnancy, every 2 to 3 years for those with abnormal liver function tests after pregnancy, or every 6 to 12 months, depending on signs of portal hypertension? Yearly with abnormal liver function test after pregnancy. That is actually the correct answer based on the EASL expert guidance. But again, I would say this is expert guidance. We're still learning more about really optimizing and individualizing follow-up strategy. But given that she has persistently elevated liver tests, she had ICP, her EASL recommendations recommending annual follow-up after that. And this is taken directly again from the EASL guidance, and it really is a very nice table summary of how you can recommend follow-up and treatments for each of these conditions. And so if I direct you to the column that says ICP, uh, generally they recommend to repeat liver tests 6 to 8 weeks postpartum, and then the second follow-up depending on lab values, either in 2 to 3 years or yearly, depending on if the liver tests are still elevated. So the patient undergoes further workup because her liver tests remain elevated. And on the MRCP, she's actually found to have a focally dilated bile duct within peripheral segment 4, extending for 1.3 centimeters. So this is a potentially concerning finding, considering that she may be at increased risk of cholangiocarcinoma. So when we think about prognosis of someone like this patient, what can we tell her about what she can expect in the future? For sure, we can tell her that she's at increased risk of ICP in future pregnancies. And in terms of risk for developing progressive liver disease, I think there's still a bit more to learn, but potentially there is a risk for future hepatobiliary malignancy. And again, for ICP follow-up, if liver tests do not normalize and there's a significant ABCB4 variant present, you can consider lifelong ursodiol therapy. Although, again, it depends on the genetic variant that is present. These are, again, guidance directly from that EASL document that I mentioned that you can review. And just to end here, in terms of managing this type of case, what other healthcare providers would you want involved in care of this patient? So you really want a multidisciplinary team here with a liver specialist, a geneticist who can help you with interpretation of the clinical significance of the genetic findings, and of course, the OBGYN team who can help with management, but also risk prognostications about future pregnancies. I will just summarize our talk today here. So again, PFIC refers to a group of rare genetic liver disorders in which abnormal bile secretion or production leads to cholestasis. The classic symptom that we think about is pruritus due to elevated serum bile levels and malabsorption. It is a challenging condition. So these conditions are not straightforward, particularly in adult settings with heterozygous carriers. And again, I think I refer you back to the EASL guidance. There's a lot that we're learning, but there are still some things that we need to learn more about in regards to individualizing prognosis discussions for these patients. Genetic testing should be considered broadly in cholestatic disease, not just in children, and family screening is essential. First line treatment includes ursodiol, but now we're excited to have availability to a second line treatment with the IBAT inhibitor for refractory or severe cases. And lastly, a multidisciplinary approach, including genetics, genetic counseling, hepatology, and OBGYN family planning, particularly in ICP, as necessary. All right, so we are out of time, but thank you so much for tuning in, and I hope you have a great rest of the afternoon.